um, to a really, really long-awaited RLR episode. It's unfortunately a little bit devoid. It's devoid of Reza, who is busy on a post-call service today. But that void is being occupied by the return of a VMR legend, and that is our very own Dr. Kirtan Patolia. Kirtan will not introduce himself because he's too shy. Kirtan is now an intern at a program in Chicago and is absolutely loving many parts, but not all parts of intern year, as he made abundantly clear, but is a VMR legend for his unbelievable dedication to clinical reasoning and also his hard work that he has done so much to keep VMR afloat, but also his humanity and his kindness. And we all admire him and respect him so deeply. And we're thrilled that he's coming back with a gift today. And that gift is a special Kirtan case, which should strike both joy and fear in your eyes as we go on a journey inspired by Kirtan. So welcome back, Kirtan. How does it feel?
Hello, good morning, friends. Rabbi is kind as always. I mean, if you have listened to yesterday's RLR clinical reasoning episode, you will realize that who is the smartest of all, So I highly recommend everybody to listen to that podcast episode we had released yesterday. And of course, I'm so excited to be back. So today was, one of those lucky days that you get an off day on Friday, because in residency, the off days are kind of chaotic. Sometimes you get on weekends, sometimes you get in between the weeks, but then the days on which I get off days, maybe VMR gets cancelled. So it's so difficult to present a case. But today, fortunately, it was the right day that Rabbi is here, and I'm seeing all of my friends. So Yasmin is there, Dr. Singh, Kiara is here, Dania is here, Hans is here, Sema is here. So it's like a so nostalgic VMR for me now. I'm remembering all the old memories. And I'm sure Rabbi is going to throw this case out of the park. It's going to be super easy for him, but it's a nice case. So I hope that it goes well.
Kirtan, I have another surprise for you.
Uh-huh.
Look who's here.
Kirtan!
Oh my God. How come? Please tell me more.
I hear your voice. I was able to tune into the VMR here at the VA, but I'm so excited for your case.
Yay. Thank you for joining.
You'll see my own little icon soon.
Sure.
Yeah, Maddie is in San Francisco this year, Kirtan, and he's joining us on rounds today.
Nice.
Doing a morning report. So yeah, very excited to have her here.
Sure.
And yeah, so for all of you in the chat, we're gonna do this together. I cannot solve a case without Prof. Rez. And instead we'll lean on you. So please share your thoughts in the chat, and we'll try to get everybody participating. If you are able to unmute and share your thoughts, if you aren't able to, just let me know in the chat. If you have your video on, I assume you're around, and we'll lean on you too. If you can have your video on, it would make my day. Please. But final thing, please, nobody say anything about the World Cup. I haven't been able to watch the game. So please don't tell me anything about the World Cup. I will cry. I promise you I will cry. All right, Kirtan, take it away, my friend.
Sure. So I have framed this case in such a manner that we have to involve more cognitive reasoning later in the case. And in the initial part, it's going to be a little bit easier. So firstly, the title of the case. So the title of the case is a diagnostic conundrum. So starting with the first aliquot, we have a 62-year-old gentleman with history of type 2 diabetes mellitus and alcohol use disorder, presenting with the chief complaint of abdominal distension, a little bit more of HPI. So he was at his baseline state of health about 4 to 5 weeks ago when he started noticing that his belly was kind of getting weaker. He also had sharp abdominal pain in the epigastric region around the same type for a week before, and then it resolved on its own. So a week later, he endorses that he has reduction in appetite as well. And over the past few months, he has lost about 10 pounds of weight. A little bit about the background of the patient. So he's from Mexico, but has been in the United States since last 18 years. And he has never visited the Mexico in last 18 years. He works in a landscaping business in Chicago. He denies recent travel, any past incarceration or exposure to animals. He denies smoking, but consumes alcohol. So he consumes about 4 to 5 beers per day and has been consuming that since last 1.5 years. And the last drink was around 30 days ago. So and apart from that, the surgical history is unremarkable, apart from the fact that he had appendicectomy many years ago in Mexico. He doesn't remember the specific details of the operation, but he told me that he had his appendix removed. So that's the end of Fasel.
Amazing, amazing. Thank you so much, Kirtan. I'll just start sharing my thoughts, and I think we'll lean on the chat in a little bit. And I'll just say that there are many things to focus on. You've given us that the patient has risk factors for many diseases by virtue of his diabetes and virtue of his alcohol use disorder, and even by virtue of his country of origin and of his disease. But all, if you could just make a list of possibilities based on diabetes, alcohol use, landscape, or Mexico, it would be almost the entire book of Harrison's. So you're much more likely to make success by studying the data that he has that you have to explain. And the data you have to explain is a very interesting combination. It's a combination of abdominal distension, epigastric pain, anorexia, and weight loss. And I think the best place to start is to start with the abdominal distension, because a general rule of thumb is whenever a disease is kind enough to coalesce or to concentrate or to show up in a very specific coalesced manner, you should just study that. It's no different than when you see a mass, you biopsy it, you'll probably find an answer. So the key question is, what is causing that abdominal distension? And this is where I want you guys to think. So there are really three distinct possibilities. The first is the belly is big because it has increase in solid material. It's big because there's an increase in liquid, or there's an increase in gas. So what do you all think? Do you all think that there's liquid in this belly, solid in this belly, or gas in this belly? What do you think? Shema thinks it's liquid. I know she can't unmute, but Shema, do you mind typing why you think it's liquid? Yeah, 100%. So Shema's using the base rate. The base rate would tell you that the most common cause of abdominal distension, subacute abdominal distension, is ascites from liver disease. So the question is, immediately, you have alcohol plus you have abdominal distension. Could this patient have portal hypertension from cirrhosis? Or could this patient have portal hypertension from alcoholic steatohepatitis? Mohammed, you have a great mnemonic here. Are you able to unmute and share that out loud? It's a really good one. If you can't unmute, just let me know in the chat, okay?
Hello, yes. Hello, everyone.
Hi.
Yeah, I was just thinking of these 6 Fs. So fat, fluid, flatus, feces, a filthy tumor, or fetus in females. So that's that kind of helped me.
Yeah.
Just
I think that's an awesome place to start. It's a really catchy mnemonic. Which do you think of those F's is at play here? What's your hunch?
I think since it's gradually getting bigger, I think it
Yeah.
might be fluid accumulating. Yeah.
Yeah, I think
So
it's really
I
tricky,
try
right?
as fluid.
Yeah, I think we're at a tension between whether it's fluid or whether it's solid. It's very unlikely to be gas. So what would gas do? Gas is usually called by bowel obstruction, ileus, or flatus, or not flatus, sorry, but oh gosh, I'm blanking on the word. What's it called? Basically, when you have gas in your dyspepsia and abdominal distension from that. So the most common feature of patients who have gas in their belly is prominent nausea. It's very unusual to have a bowel obstruction or ileus without nausea. So I think it being gas is very, very unlikely in the absence of nausea or vomiting. And so the question is it liquid or solid? And the curious thing is that most of the time when it is liquid, when it is ascites, there is lower extremity edema. And the absence of lower extremity edema should make you think, wait, is this organomegaly from hepatomegaly or splenomegaly or a big malignant tumor? And so I'm really trying to pay attention to the possibility that this might be solid because there's no edema, but also it's very easy for patients when they have so much going on in their belly not to notice the edema. But this isn't just abdominal distension. This is abdominal distension with weight loss. When the abdomen distends and fills up, you expect the patient to gain weight. And the fact that this patient has lost weight despite accumulating more mass in their abdomen is very intriguing and points to a hypercatabolic process. It's very unlikely this patient has cirrhosis, despite the fact that he has alcohol use and abdominal distension. It's because he's lost a significant amount of weight so quickly, which would be unusual for the chronic, slowly progressive disease that cirrhosis is. Now, he could have had cirrhosis for a long period of time, and then now is presenting more acutely because he is decompensated in the form of developing a hepatocellular carcinoma, which goes to show you that this solid structure, HCC, may be accompanied by liquid from ascites. So this exercise is artificial. We're confident that the patient doesn't have any gas, and the question is, it's solid or liquid? My advice, use your ultrasound right now. Don't wait, because if you know that this is ascites, you will be able to make tremendous progress going forward. All right, Kirtan, do you want to tell us more?
Sure. So that's the amazing start. I love how you posed the question of ascites accompanied by weight loss. And I think that's going to be crucial moving ahead. So moving to the second aliquot, talking about the vitals. So patient is hemodynamically stable, saturating well on room air. The heart rate was 98 beats per minute and the blood pressure was 112 over 80 millimeters of mercury. And the respiratory rate was 15 breaths per minute. And pertinent examination findings. So talking about the respiratory system, lungs were clear to auscultation, respirations were non-labored, and breath sounds were equal. Cardiovascular examination was also unremarkable with normal S1 and S2, no murmurs, normal rate and rhythm. Talking about the examination of GI system. So it was soft, non-tender, but there was abdominal distension with positive fluid thrill. Apart from that, there was no evidence of any organomegaly. Talking about the extremities, so patient had bilateral pitting edema, noted up to the level of mid-shins, and it was most pronounced around the ankles. I am also going to give you some basic labs so that we can start the wheel rolling. So CBC was within the normal limits. Talking about the basic metabolic panel, the sodium levels were low at 122. Potassium was 4.5, chloride levels were 99, bicarb was low at 16, BUN was normal at 19, and creatinine was also normal at 0.6. Total protein was 5.8, albumin was low at 1.8, total bilirubin was elevated at 2.7, direct bilirubin elevated at 1.7, AST 89, ALT 29, alkaline phosphatase 229, gamma glutamyl transferase 133, LDH 151, which is the normal range for LDH. PT was elevated at 17.6, INR was 1.49, and APDT was elevated at 49. And given the fact that we were dealing with hyponatremia, I also wanted to give you a little bit about the serum and urine osmolarity. So the serum osmols were 266, urine osmols were 543, and urine sodium levels were less than 10. So that's the end of second aliquot.
Absolutely amazing. I think we've added so much to the context that we've been working in. First, we said that this was abdominal distension with weight loss in a patient with alcohol use disorder and diabetes who has some travel-related exposures. That was where we started. And we've made a lot of progress because now we've confirmed that this abdominal distension is in fact liquid. And even before you do the fluid exam, the fact that he has liquid in his legs prioritizes liquid in his belly. So now we're dealing with ascites in a patient with weight loss. And the question is, how can we understand the ascites better? And there are both things that are very helpful here that are positive, and also things that are helpful because they are negative. So 1 second. Hi, it's Robbie. Hello? Oh, alrighty. Somebody doesn't want me to talk here, clearly. So What is helpful and what is helpful that is positive? The degree of hyponatremia here is important to analyze. And the mechanism of hyponatremia is that this is very likely the ADH excess, appropriate ADH excess. So first we confirm that the patient is in fact hypoosmolar because their serum osms are low. The urine osms being elevated mandates that ADH is involved, and the question is ADH appropriate or inappropriate? And the low urine sodium confirms that the ADH is in fact appropriate. And so the question is, what is driving that ADH status? And that's where we have to go back to understanding the mechanism of ascites. So you see here, the sodium doesn't help us too much in making tremendous progress. So if we look closely at the liver numbers are concerning. The patient has an elevated alkaline phosphatase, an elevated GGT, and also has an elevated INR, elevated total bilirubin, and a low albumin. All those markers tell us that the patient has significant liver disease. That shouldn't come to too much of a surprise because we know, hello? Wow, okay. The patient has significant liver disease, but the question is, does the patient have liver disease causing ascites? Many patients have liver disease without ascites, for example, patients with acute liver injury. So the question is, how do we prove that ascites is related to liver disease? And that's through findings suggestive of portal hypertension. The most specific sign for portal hypertension is to tap the ascites and study it for the serum ascites albumin gradient. But you can make an educated guess before that. What are other signs of portal hypertension? You might see caput medusae or dilated veins on exam. You might see evidence of rectal varices if you were to look for them. But most importantly, you will almost always see thrombocytopenia from splenic sequestration. So the lack of thrombocytopenia here is very, very telling and reduces significantly the probability of portal hypertension. However, that probability is tempered by the fact that there's evidence of shunting away from the kidney. So there might be hepatorenal physiology here by virtue of the ADH. So there's suggestion of portal hypertension because there is ADH-driven hyponatremia in the context of liver disease, but the argument against portal hypertension is the presence of normal platelet count. So the SAG will be really, really important. I think it's crucial to not make the mistake and to say liver disease plus ascites plus evidence of hepatorenal physiology by evidence of ADH equals portal hypertension. No, the platelet count being normal is a big red flag. Big red flag. And so the question is there anything else to support that momentum that that red flag gives us? And the answer is yes. 10 pounds of weight loss is so unusual in patients with cirrhosis that also is a red flag directing us somewhere else. Now we have to be very careful. We have to be very careful because our analysis is so biased in these cases to try to find one unifying cause. Could this patient have cirrhosis from their alcohol use and now have a separate intra-abdominal problem? And that has to be entertained too. We might be dealing with an and situation, not an or situation. So to summarize, is there evidence of liver disease? Yes. Is there evidence of ascites? Yes. Is there proof that those are connected? Some proof, but also some red flags that we should maintain a disconnect until we can link them more closely. So tapping this ascites is going to be very, very informative.
Sure. So guys, I can give you the next aliquot. And I just wanted to point out that how important is Rabi's discussion, that sometimes when you are dealing with complex cases, it's important to ask the right questions, because if you don't ask the right questions, you will never find the right answers. So what Rabi said was extremely instrumental, that how can we reconcile the fact that patient doesn't have thrombocytopenia despite having other signs and symptoms of liver disease, and could this be two processes at play? So for the third aliquot, starting with some imaging studies, so the chest x-ray was obtained and it revealed right lower lobe ground glass opacities with mild to moderate pleural effusion, and upon further evaluation it was found to be exudative in nature based on the lights criteria. Then we also obtained the CT abdomen and chest with contrast because there was suspicion that patient has weight loss. And now with these opacities, we are thinking that what if there is something more than just those opacities in the right lower lobe, and maybe CT scan can clarify it. So talking about the CT abdomen and pelvis, we found the evidence that there was cirrhotic liver morphology with evidence of portal hypertension given the dilated upper abdominal collaterals, and there was small to moderate volume ascites. Talking about the CT chest, we had evidence of partially calcified mediastinal and hilar lymph nodes and prominent bilateral cardiophrenic angle lymph nodes. Pleural fluid analysis, talking a little bit more about that, like what we exactly found. So although it was exudative in nature, but the RBC count was also elevated, and the number of RBCs in the pleural fluid were more than 300. The adenosine deaminase levels were elevated at 53.2 in the pleural fluid. Negative cultures, negative AFB and gram staining. The cytology was also negative for any abnormal or malignant cells. Peritoneal fluid analysis, as Rabi was telling us, that's going to be instrumental. So the analysis revealed that it was a bloody tap. So the RBC count was more than 500. The SAG ratio was 0.7. So it was less than 1.1. And the total protein of the ascitic fluid was 3.1. We also obtained the transthoracic echo because always while working with the cirrhotic pathology, you always worry, could this be cardiac cirrhosis? So the TTE was unremarkable. So ejection fraction was 55%, and there was no evidence of constrictive pericarditis or any valvular pathologies and no regional wall motion abnormalities. The CEA and CA19-9 levels were also elevated. So carcinoembryonic antigen and CA19 levels were elevated. And since there was high concern for malignancy, given the weight loss, given the lymphadenopathy, and given the elevated levels of tumor markers, the peritoneal exploration was performed, and peritoneal exploration revealed dense peritoneal adhesions along with peritoneal implants. And that concludes our third element.
Wow, Kirtana, this is quite a twist. I think we should all just take a moment to reflect on where we are. We started with abdominal distension, and now we have ascites, and we actually have made two diagnoses now. The patient has significant alcohol use, has liver dysfunction, and has evidence of cirrhosis on imaging, likely suggesting a high probability that this patient has some degree of chronic liver disease. So that diagnosis is almost sealed, but we have proven that there is a disconnect between that diagnosis and other findings in this case. And this patient has features of inflammation within his fluid that suggests the diagnosis of cirrhosis is insufficient and does not capture everything. So what is that evidence of inflammation? Is that the patient has an exudative pleural effusion and has exudative ascites. And so the question is, well, what causes exudative serosal diseases? And the summary is that any cause of inflammation can cause an exudate. However, infections on cancers are much more common than autoimmune diseases to cause exudative serosal inflammation. So this always becomes a tension of, is it infection or is it malignancy? There are many clues along the way, but biopsy is the ultimate definitive test because the microbiological sampling of fluid is insufficient to be confident that an infection is not at play. So that's all you need to know. Exudate is usually infection or cancer, and unless your microbiology on the fluid is positive, you usually need to proceed to serosal biopsy because the microbiology yield is not enough to exclude infection. So what's the typical arc for these patients? We sample the fluid, we see, is there an infection or is there a cancer with microbiology and cytology? And if there is none of each, we proceed to biopsying the surface. But we should proceed with a pretest probability based on other data we have. So let's analyze that other data. That other data in this situation is that the patient has lymphadenopathy, has hemorrhagic pleural, has hemorrhagic features on the pleural and pericardium, has dense adhesions, has a high adenosine deaminase, and has a high CEA and C19-9. So how do those features help us? In general, the more hemorrhage you see, the more likely you're dealing with cancer, because cancers form abnormal blood vessels as part of dysfunctional angiogenesis. However, infections can also have a hemorrhagic component. You also can, when you form cancers, can commonly secrete tumor markers like CEA and C19-9. However, there are many infections, namely tuberculosis, that can cause elevated CEA and C19-9. So how do we, and I should say, adenosine deaminase positivity has a great predictive value for tuberculosis in areas where tuberculosis is hyperendemic. However, cancers are also elevate the adenosine deaminase test. So you can see how it is literally impossible to be confident what this patient has. And it's a tension between, do they have a granulomatous infection or do they have a malignancy? How do we make progress? The site of origin of the disease is very helpful. Most granulomatous infections enter into the body via the lungs. And this patient having lung findings on the CT chest with calcified hilar lymphadenopathy brings in the possibility of chronic granulomatous infections, including tuberculosis, brucellosis, and many, many others. However, he also has ground glass opacities in the right lower lobe, which may be suggestive of a focus of adenocarcinoma that then invaded the pleura and the peritoneum. So it's very easy to know what the next step is. The next step is you cross your fingers and you hope that the cytology or flow cytometry or microbiology is positive. But ultimately, the need for a peritoneal or pleural biopsy in this patient is very, very high. How could we be fooled? There's one important test to consider in this patient, and that is a triglyceride level to make sure that we're not dealing with chylous ascites, because chylous ascites can masquerade as an exudative ascites because the albumin is low in chyle. So I'd be really interested to know what the triglyceride level is. I think it's humbling that this patient almost certainly has multiple diagnoses, with cirrhosis being one of them, but also another one hidden underneath. Importantly, we have to now also look back in time as we look forward in time and say, is there any clue in the medical history that suggests anything else? We talked about his residence in Mexico being a risk factor for TB and brucella or Mycobacterium bovis. His landscaping exposure exposes him to a variety of endemic mycoses, including histoplasmosis and sporotrichosis. But importantly, his history of appendectomy might be helpful, because if the reason he had appendicitis was an appendiceal tumor, he might be having a mucinous recurrence of the tumor, which can cause an exudative ascites and cause peritoneal implants. So his history of appendectomy might be relevant as well. All right, Kirtan, tell us more, please.
Sure. So exactly as you said, Ravi, we are also considering that could this be two possibilities, and we need the tissue sample to move ahead. So before that, I wanted to mention that the triglyceride levels were within the normal range. So that's a nice thing. And now, before I give you the more data, I also wanted to summarize the case so far. So actually, I just copied, pasted all the things from my note, like when I saw this patient and how did I summarize it. So in my note, I wrote that we have a 62-year-old gentleman with history of diabetes mellitus and alcohol use disorder, presenting with subacute onset of abdominal distension and weight loss. His salient features of presentation include evidence of cirrhosis and portal hypertension on imaging studies, exudative pleural effusion, low sag ascites, hyponatremia, hypoalbuminemia, elevated INR and APTT, cholestatic or infiltrative pattern of LFTs, elevated CA99 levels, and dense adhesions with multiple peritoneal implants noted on peritoneal exploration. So although he has evidence of cirrhosis and portal hypertension, low SAG points to exudative causes of ascites, including infections like tuberculosis, histoplasmosis, blastococcidio, paracoccidio, brucellosis, Burkholderia, malignancies including primary peritoneal mesothelioma, sclerosing encapsulating peritonitis, pseudomyxoma peritoniae, peritoneal metastasis, or serositis or infiltrative granulomatous conditions like sarcoidosis. His cholestatic pattern of LFTs can represent the alcoholic injury, sarcoidosis, amyloidosis, lymphoma, parasitic biliary invasion, or cholangiocarcinoma or hepatic angiosarcoma. So this was how we summarized in our note. And then finally, we obtained the peritoneal biopsy. So this is how the biopsy results were. So focal mesothelium-lined fibroadipose tissue with chronic lymphohistiocytic inflammation and prominent non-necrotizing granulomatous with multinucleated giant cells. Spatial stains, including acid-fast bacilli stain, Phyte stain, and GMS stains are negative for fungal organisms and acid-fast bacilli. The serum ACE levels were within the normal range. And this is the end of Aliquot 4.
Superb, Kirtan. I think that the real value in this biopsy is its incredible negative predictive value against malignancy. So the fact that you do not see a malignant focus here dramatically reduces the probability that this process is malignant. And I think now you can say that this patient's inflammatory disease process appears to be chronic because the chronicity is reinforced by the calcified lymph nodes, reinforced by the dense fibrotic adhesions, and reinforced by the non-caseating granulomas that were found. And so at the end of the day, what's our DDX for non-caseating granulomas? And it's most informed by the chronicity. The chronicity here appears to be marked, and there's only really a couple of causes of chronic granulomatous disease. One is the chronic granulomatous disease diagnosis itself, an immunodeficiency condition. But the other is sarcoidosis, which would be a leading consideration in this patient, given the lymph node pattern, recognizing that the ACE test doesn't align with that fully. And then the other diagnosis is what's called foreign body granulomatosis, where a patient has a granulomatous reaction to some form of foreign body. Now, how would that happen in the peritoneum? There actually is a large number of focal peritoneal diseases that are reactions to antigens. There is peritoneal melanosis, peritoneal splenosis, and some other ones that I'm forgetting that that all have to do with an abnormal reaction of the peritoneal surface to an antigen that's perceived as exogenous. So what have we done here? I think the biopsy significantly reduces the probability of cancer. You would have to wait for 6 weeks to be confident that the AFB culture is negative, excluding the possibility of tuberculosis. But now you can start to veer towards saying, hey, this is a chronic granulomatous issue, unlikely. And that chronic granulomatous issue is usually either sarcoidosis or that the patient has a foreign body type reaction. The foreign body type reaction is reinforced by the presence of multinucleated giant cells. So what would I do now? I think it's a question of whether you try to get another piece of tissue to capture the imperfect nature of tissue sampling, or you begin to initiate systemic immunosuppressive therapy and watch for how the patient progresses. The leading considerations, I think, are a systemic autoimmune granulomatous disease or a focal peritoneal disease process that is induced by a foreign body or a foreign antigen mismatch. You may wonder, well, how does that explain? Is there anything else that's left unexplained? The cirrhosis is explained by alcohol use. The pleural effusion is simply explained by the transmission of the exudative in the belly up into the lungs. So the only part that would be not fully explained is the lymphadenopathy, if that were ultimately determined not to be related to sarcoid. So a very complicated case, a hard decision to start to treat the patient empirically, um, or to get another piece of tissue, either from the peritoneum or from the lymph nodes if they're accessible bronchoscopically. All right, Kirtan, mic to you, my friend.
Sure. So this is the final rally quote. And I just wanted to, again emphasize that how Rabi's clinical reasoning and the streamlined thought process almost reached us to the diagnosis. And we actually got the diagnosis as well. So if you look at this case retrospectively, there are various data points which can guide us toward one particular diagnosis, but it's hard to reach to one conclusive diagnosis. And it is important because the treatment of sarcoidosis is steroids, and especially given the fact that if this turns out to be sarcoid peritonitis, then it's like very fulminant and very dangerous. So we give high dose steroids. But if you give that, and if you are not sure whether this could be tuberculosis, then you would throw the patient into TB flare, and patient can have a fulminant course in other organs, like patient can develop TB meningitis, patient can develop fulminant TB peritonitis. So that's why we were confused at what to do. And if you just look at the fact that, let's say, patient is alcoholic, patient is not from Mexico, let's say, and if you see those liver enzymes, then you will think that this is classic case of alcoholic ascites. But then if you throw in the picture the fact that SAG was low, then immediately you think about that, could this be malignancy? Could this be tuberculosis? Because those are the two main causes of exudative ascites. Now, let's say if you take out the low SAG part, and if you just think about the fact that elevated alkaline phosphatase, elevated GGT, elevated TBL, then that points toward infiltrative condition, and coupled with the mediastinal lymphadenopathy, you would think about sarcoidosis. So all these scattered points and all the three possible diagnoses are there. But eventually, the thing that captured the diagnosis was the growth of bacteria in the cultures. So as Rabi said, that TB is TB, like it's so difficult to rule it out. Like sometimes even when you have, let's say, ascites or pleural fluid accumulation, the growth is not going to be there anyways, because sometimes people believe that the ascites and the pleural effusion is kind of hypersensitivity reaction to TB and not actually because of the bacteria in the pleural fluid. So what you need is the pleural biopsy or peritoneal biopsy, which can guide you toward the fact that whether this is indeed TB or not. And now regarding the granulomas part, so we know that sarcoidosis is kind of an autoimmune disease towards an unknown antigen. So we don't know that what causes those granulomas. Those immune cells are reactive against what antigen? We don't know. So like, for example, there have been studies which suggest that people who get histoplasmosis earlier in their life or who are exposed to histoplasmosis, eventually they end up developing sarcoidosis. And similarly, there have been associations with tuberculosis as well. And the non-necrotizing part and the necrotizing part, it's often confusing. I mean, sometimes people with sarcoidosis can get necrotizing granulomas, and sometimes people with infections like TB can get non-necrotizing granulomas. So even that part can't guide us forward. So finally, 6 weeks, I think not even 6 weeks, 7 weeks into the course of disease, there was growth of Mycobacterium tuberculosis in the peritoneal fluid, and Mycobacterium tuberculosis PCR was also positive. So the final diagnosis would be tuberculous peritonitis with sarcoid-like reaction or sarcoid peritonitis. And it's hard to say, but given the overwhelming fact that patient was from Mexico, patient had this weight loss and all these features, the more diagnosis likely was TB peritonitis, which may be sarcoid-like reaction, but not sarcoid peritonitis. That's why the patient was commenced on the therapy that we use, like isoniazid, rifampin, pyrazinamide, ethambutol, and patient is doing well so far, and we will keep on following him, and let's hope that he recovers as soon as possible. So that's the end of my case, and thank you so much, Rabi, for dissecting it so early on in the course that there could be 2 or 3 potential diagnoses, and the final astute point that we should wait for 6 weeks and then jump to the diagnosis despite the overwhelming biopsy findings.
My dear friend, I'm so glad you came back and you brought TB with you. What a great, incredible case. Highly, highly educational. I think that at the end of the day, you really need to be, you can never diagnose sarcoidosis, ever diagnose sarcoidosis until You've watched the patient get better with treatment. We say sarcoidosis is a diagnosis of exclusion, but it's a diagnosis that you can never make upon discharge. A patient gets diagnosed with sarcoidosis at their home when they never come back to the hospital because you treated them. You can never have a discharge diagnosis of sarcoidosis, I believe. And so I think at the end of the day, what is the major red flag now that we can breathe and reflect on this case? The major red flag against a diagnosis of sarcoidosis is the patient's age. The vast majority of patients with sarcoidosis will present younger than 55. And new onset sarcoidosis in this patient is extremely unusual. Now, at the end of the day, I think, Kirtan, what you taught us is how important it is to actually be open to multiple diagnoses. So on your past medical history, you have diabetes, type 2, and alcohol use disorder and appendectomy, but now you can add another diagnosis, TB peritonitis, but another diagnosis, which is alcohol-induced cirrhosis. And I think that that is actually related, because you may ask, why now? Why did this patient who hasn't been back to Mexico in 18 years reactivate their tuberculosis? And of course, the diabetes played a role, but the fact that he developed cirrhosis, immunocompromising him further, as a result, opening the floodgates for TB to do its treacherous thing. So you have to be very careful in patients with cirrhosis. They are at risk of getting ascites from the cirrhosis itself, but they're also at risk of the immunosuppression that comes from liver disease that awakes a sleeping giant, a giant that's been sleeping inside this person for 18 years, suddenly comes to life. Yeah, at the end of the day, the only way out of the world of entertaining tuberculosis, the only way out is if the patient's culture is positive, or if the patient responds to empiric ripe. So there are many cases, even with TB, where you don't get a microbiological answer, and you have to treat the patient with ripe empirically and know that they responded. So how can you ever say that this patient cannot have tuberculosis? You cannot say it ever based on microbiology, because even waiting 6 weeks, the sensitivity of mycobacterial culture is about 95%. So there's still 5% of people who have tuberculosis, active tuberculosis, who don't grow it on culture. So what's the only way you can exit the world of tuberculosis comfortably is if you treat the patient with ripe and they do not get better. That's the only way. And even that has a caveat. They could still have tuberculosis, multi-drug resistant tuberculosis. So you'll never be able to say this person does not have tuberculosis confidently. And I think this is a fantastic example of that. So much learning here, a case of a dual diagnosis of new cirrhosis and TB. Thank you so much, Kirtan. I don't even know how to transition to the teaching points. And I'm curious if you had to say, when did you start to think that tuberculosis was the leading diagnosis? When did it start to become the focal point of your thinking?
Sure. So thank you again, Rabi. Often on VMR, we don't get a chance to hear your raw thinking as much. So today was like one of those VMRs where we get to listen to you long time. So thank you for that. And yes, so the main point where we thought that, well, this could be TB was the SAG ratio thing. Because now, of course, in people who have alcoholism, and let's say if they have portal hypertension, and if it is induced transudative kind of ascites, then the SAG would be more than 1.1. That's important. But if we look at the total protein, that is also a very important point, because in people who have cirrhosis, and if they have ascites, then the total protein is less than 2.5, almost always, certainly. So the fact that our total protein was more than 2.5 made us wonder that this cannot be just cirrhosis, because okay, SAG can be tempered by so many things, but what about the total protein in the ascitic group? So that was also a key turning point. And apart from that, there was one more point which I wanted to mention, that this patient was from Hispanic heritage. So if we even think about it, then things like sarcoidosis, things like systemic lupus erythematosus, they are more common in people who have African American background. And in people with Hispanic heritage, it's very, very unlikely that they will have sarcoidosis, and especially at the age of 62, as Rabi mentioned. And the fact that he was from Mexico, again, heightens our suspicion. Then the weight loss part, of course, sarcoidosis can cause weight loss, but then TB is like the elephant in the room. We cannot neglect it, right? So that was the turning point. And apart from that, when they did the peritoneal exploration, the surgery team actually directly communicated with us. Like they didn't even page us. They like came straight to us and talked to us face to face that, hey, those implants which we found on the exploration, like it's certainly TB. Like they have never seen implants like that anywhere else. So certain, it's like pathognomonic. Like when they see those characteristic implants, it cannot be seen in any other disorder. So that's what our suspicion was so high. That's why we waited for the cultures despite the non-necrotizing granulomas part. And eventually the cultures results positive. So we were rewarded for our patients. And finally we started him on type therapy. So that's how the case was resolved.
Incredible, absolutely incredible. It's amazing to see our surgical colleagues confident with TB just based on their visual inspection. Well, what an incredible journey. I know Shema can't unmute to recap the teaching points. I think you covered them very well there, Kirtan. So they'll stand there on the whiteboard forever to remind us of your great teaching and this incredible case. Thank you all for hanging out. Thank you, Kirtan, for your wonderful return to VMR, and hope the rest of your intern year goes well and that we get to see you again here soon.
Yeah,
All right,
thank
you again. Thank you. Bye.
Bye.